So this is a case of a 10-year-old boy who was receiving high-dose methotrexate with leucovorin rescue. It's one of the chemotherapy regimens for sarcomas used at our hospital. Each patient clears the methotrexate at different rates, and one wants to see the levels decrease to a certain level before the patient is discharged and before the leucovorin is completely stopped. Otherwise, the patient will have toxicity. So these are super toxic levels that the patients will achieve, and the leucovorin keeps the patient from having the toxicity. So on day one, the level was expected, that is in the range expected after the high-dose methotrexate. However, on day two, it was very, very low, indicating that perhaps it had cleared more rapidly than usual, and the leucovorin was halted. The physician thought, however, based on prior times the patient had had methotrexate at this dose, and based on his clearance of it, that the patient had cleared too rapidly and wanted us to troubleshoot that particular test. The tube was retrieved, it was properly labeled, and the test was repeated with exactly the same results. The patient was kept overnight because the physician was being very cautious and continued on hydration therapy and had another level. The next day, day 3 of the course, however, the level was still in the toxic range and logarithmically higher than it had been the day before, which of course is impossible. So what went wrong? Well, the way the process is supposed to work is depicted in this slide. The nurse draws the specimen from a line, which of course can result in errors, but those errors would be high, not necessarily low. It's tubed to the laboratory. The specimen is divided into routine testing and aliquoted for specialized testing, in this case the methotrexate level, performed in a different section of the laboratory. That section picks up the specimen, reconciles the identity of the specimen on a worksheet, and then performs the assay. After the assay is performed, there's a two-tech verification since these instruments are not interfaced with our LIS. So what happened in this case? It turns out that with investigation, shown in this slide, that the Aliquot bench was staffed by fill-in technologist, someone who in fact had been trained for that position but did not regularly work the position. And we had a lot of samples at the time, so there were multiple specimens on the bench. The routine test results match the patient, so we know the identity is probably correct. There was not a mislabeling of the specimen at the point of drawing the specimen, and since those routine tests had matched the patient, the specimen was probably not susceptible to a line dilution effect. What most likely happened is that another patient not on methotrexate received the Aliquot specimen that belonged to this particular patient. Our mistake was that we did not ask for a new specimen, but rather just checked that specimen. More importantly, we had nothing in our procedure to question what happens when we get a 0 methotrexate level. Certainly in all of your laboratories, you see 0 levels on certain therapeutic drugs, particularly those that have been stopped while the order has been continued for subsequent testing. So it's not unusual to see a 0 level. On methotrexate, however, that is a very unusual result for us to see. So what are the big problems in this area? The first one was really at the Aliquot bench, and there are multiple problems around it. And there are other areas where we could have instituted some error proofing. So the solution turns out to be complex if you really want to make sure it's not going to happen again. And we know that aliquoting is an area of risk in our laboratory, and this was not the first and unfortunately not the last time that this has happened. So we decided that we would make some changes in that, and they are depicted in this slide. So we checked the stability of methotrexate in whole blood to see if we could actually avoid aliquoting the specimen altogether. Some laboratories would require a completely separate tube for a drug level from routine testing, and that of course might be preferable, but in this particular case, in our particular hospital, which is a pediatric hospital, we really emphasize to decreasing the amount of blood drawn from the patient. So we tend to aliquot and share tubes, really sometimes to our disadvantage, but hopefully most of the time to the patient's advantage. We do try to restrict, and we've continued to restrict, who can work on that bench, but as I said, the particular person working there was qualified and had been trained. They had just not done a lot of different or work there on a consistent basis. Throughout the laboratory, we try to emphasize using single piece flow, and certainly on the aliquot bench, that is our goal. And we have subsequently done more work on the aliquot bench to try to ensure that only one patient's sample is on the bench at one time, so that there's a separate area of the bench where specimens can line up, but then when they're moved for the actual aliquoting process, they are only that patient is there with that patient's labels. We have also tried to increase the competency of the person working that bench by restricting who can work there, and for our reserve pool, rotating them through the area more frequently so they can have the experience. Then we talked a lot with all of the staff, not just those involved, about what actions should take place when a physician calls questioning a result. Clearly, wrong blood and wrong tube is often what we think of first, or second. Line dilution is what we think of first in our laboratory. But that often, as you see in this case, is not the explanation. And then what we finally did in this particular case is we packaged everything together as a teaching scenario to spread to everyone in the laboratory, because it's not just about methotrexate and about aliquoting. It can happen elsewhere in the laboratory where we have the possibility of mixing up patient samples and labels, and where we might not respond to a questionable result in the same way.